is on enclosed infections. And for this, I would like to invite Dr. Taneja, Dr. Ellen Taneja as speaker. Can we see the CVs? Dr. Taneja is a consultant pediatrician at Max Hospital, Patparganj, and one of the most senior practicing pediatricians in Delhi. I welcome you, sir. Please come. For panelists, we have very eminent Dr. Chugh. Needs no introduction, I suppose. Pulmonary pediatric specialist and worked at Gangaram and then now at Fortis. And Dr. Manish Narang, sir. Dr. Sanjay Saroop. Welcome you, sir. And for chairs, I would like to invite Dr. K.K. Jani. Yeah. Dr. Raghavendra is there. Dr. Raghavendra, sir, please. Then Dr. S.S. Meena. Please, sir, as chair. These CVs are for the next session. I welcome Dr. Taneja, sir. Please take over.
Thank you very much, organizers, for giving me this opportunity to be over here with this august panelists with me today. We very frequently face this situation in clinical practice that antibiotics are not working for our child, our patients, and the fever is not responding. So this pushes us to, a corner where we have to explain things to the parents, we have to find ourselves what is the reason, and we keep scratching our head whether we are using the right antibiotic, whether we are our diagnosis is correct, whether we are missing any thing in the examination, or there is some hidden infection somewhere in the body which we are not able to identify. So we are going to dwell upon this particular aspect of the medical condition or the disease process in our patients. Today we have a wonderful panelists over here with us, very experienced in their respective fields. We have chosen three areas of interest today. One is the lungs, the second is the liver, and the third is the bones, where infections can get hidden and may be difficult to identify and may be difficult to approach and pose some clinical challenges to manage those situations. So here we have the experts, Dr. Chugh. Dr. Krishan Chugh needs no introduction to this audience. Everyone knows across the country and outside the country also. Dr. Chugh has been a pioneer in respiratory medicine in pediatrics for a very, very long time. I think he is one of the first ones who began this discipline in our country. If I am not mistaken, all of us have practically learned this art of dealing with respiratory conditions in pediatrics from you only, sir. So welcome, and over here is Dr. Chugh. We begin with a very simple case. A 5-year-old child comes with a fever and chest pain and tachypnea, mild retractions and mild cough for 5 days. His air entry is decreased on the left side in infrascapular region with bronchial breathing in the interscapular region. Polymorphin nucleocytosis is there, leukocytosis is there with raised CRP. Sir, if you can define a brief approach for this particular case. Looks like a syndemonic effusion on the face value. How do we proceed?
Well, first of all, congratulations to the person who has done a physical examination and found that there is a bronchial breathing. It's a dying art, and most people are not putting a stethoscope, or even if they put it, they don't realize what they are hearing. So, anyway, it's quite clear that there is a pneumonia on that side, and since breath sounds are also not very loud, they are decreased, so syndemonic effusion quite possible. Polymorphin leukocytosis and raised CRP do suggest that it is quite likely to be a bacterial infection. The approach would be that first of all we confirm this diagnosis and still, although ultrasounds can be done to identify pneumonia as well as effusions. In fact, for effusion, it may be even better. But an X-ray test would be the starting point to look at what type of pneumonia, what is the extent, and if by chance already you find something, although it's only a 5 days, sometimes you can get a clue. For example, necrotic pneumonia, where you know that Staphylococcus is more likely organism and that you would cover for that. Otherwise, a general antibiotic in a patient who's been admitted, hospitalized, we generally use ceftriaxone. Those who are on the OPD basis, I prefer cotrimoxazole.
So if we find fluid,
Comoxiclav.
so if we find fluid in this particular chest X-ray, should we go for a diagnostic tap or not?
Let me show the next slide. I'll take this case. We handled this case just about a month back, or maybe less. This was a 6-year-old who had 4 days fever, cough for 4 days, breathing difficulty 2 days, no response to treatment, tachycardia, tachypnea, febrile, bronchial breathing right side, CRP is 470, TLC is 9,700, polymorphs are 92%, blood culture is negative. Next. So he had already come to me with this done from the nasopharyngeal swab. Now nasopharyngeal swab, it was a coronavirus positive, which is not the COVID virus, and you know that in this biofire, this does not have much of significance for us. Mycoplasma was negative. That was one test, one organism which was quite at least possible in this patient. But bacteria were not tested because in nasopharyngeal swab, that is not a part of the test. So to me, this test should not have been done. Next, when the X-ray was done and then a CT was done, this is CT pictures, which clearly show a pneumonia on both sides, left as well as right, anteriorly as well as posteriorly. Next, please. And this is the CT scan done, which shows a pneumonia, a significant pneumonia on both, and on the left side you can see, in the left picture you can see, okay, left picture you can see the effusion also, significant amount of effusion. Next, please. So a tap was done, and this is the fluid that is coming out. Does it look tubercular? Maybe somebody can call it straw colored, but to me it is not exactly straw colored. It is a thin pus. That is what I would describe it as.
More hazy than the usual straw color.
So that's what it was. And culture came negative. Cells were 993 with 28% polymorphs and not mainly polymorphs. Now, again, we are in a dilemma. What to do? Next, please. This was day 6. Antibiotics are going on. Vancomycin had been added to ceftriaxone, thinking that it could be either a staphylococcus infection or a pneumococcus, which is resistant to the ceftriaxone, which means resistant to the first line antibiotics, penicillin or amoxiclav, whatever. So the fever is persisting and pneumonia not responding X-ray wise also. Next. So day 7, a CT scan was asked for, and now you can see that the effusion is still there and a peel has started forming, which is enhancing. I hope you have noticed a difference. In the previous CT scan, contrast was not given. Here, contrast has been given, and you can identify the peel there. And if once a peel has formed, 7 days of antibiotics already given, patient not responding, this is a patient where we need to intervene. Next. The question comes up is, should we, I think we'll come first describe this. So wax was done and everything got cleared. There are tubes on the next day. Next, please. Tubes cleared, and histopathology of whatever pleura was removed showed that it was the empyema, tuberculosis was negative. So these are the questions that come to our mind, and let's try to find answers. Should all pus be managed by ICD? Should we have used a ICD in this patient, an intracostal drainage, rather than a tap just that we did initially, or the VATS that we did on the day 7 or day 8? Now, it is very difficult to decide in a particular patient what exactly we should be doing on. It's just basically some guidelines and some experience. On the first time when we saw that thin pus, my instructions were that take out as much pus as you can, you're already in that space, and then since it is looking very thin, let's wait and see if that antibiotics will be able to decide on the basis of the pus that we are draining, and if by chance we need to change our antibiotics, we'll do that, otherwise we'll continue this. So this was done, but the fluid collected again. And then on day 7, day 8, when we did a repeat CT, it was showing a peel formation. And as you saw, there was significant effusion, significant pneumonia. So we decided there's no point putting a ICD at this stage. Probably what we should do is directly go for valves. So if you have put a ICD, the next question comes is, when do we remove it? When do we think that it's okay to remove? When, of course, the patient should be improving, but sometimes fever can continue because there's an associated necrotic pneumonia, and that will take its time in spite of the correct antibiotics, which I told you most commonly is Staphylococcus. Then we will remove the ICD when approximately 1 ml per kg of or less than that volume is coming out in the ICD. And many a times you can make out that the column should not be moving too much. If the column of the fluid is moving too much too fast, too vigorously, then there are two possibilities. Either it's a bronchopleural fistula developing, be very careful, or your tube is partly out, the tubes generally have two holes in them. If one of them is out and it's exposed to atmosphere, the column will move too much and you may be misguided. So just be careful on that. So that would be when to remove it. How long to treat with the IV and oral? IV is, if it is a Staphylococcus type of pneumonia and the patient is not responding as quickly as you would like, to at least 1 week of IV antibiotics. After that, you'll have to individualize. Generally speaking, at least 3 weeks of anti-Staphylococcus antibiotics are required if you are treating Staphylococcus. If it is a pneumococcus, 7 to 10 days.